Dr. Kyriakou is an associate professor and chair in the Department of Health Professions at Hofstra's School of Health Professions and Human Services. Dr. Kyriakou has been a professor on our campus for over 10 years and is the founder of our Master of Public Health program, as well as our National Public Health Week event series. Dr. Kyriakou is a dedicated and passionate educator who continually strives for opportunities to engage with the local community and to provide health equity and access to those who are most in need. Dr. Kyriakou, without further ado, it is my honor to ask you to take over the event this evening.
Thank you so much. Good afternoon and welcome to Verifying Vaccines Beyond the Myths. I'd like to thank the Dean of Hofstra School of Health Professions and Human Services, Dr. Holly Syrup, for sponsoring this important and very timely event. Also, many thanks to Assistant Dean Tony Porcelli for his work managing all of the event logistics. The US reported its highest number of COVID-19 deaths last week. In fact, the 5 highest, sorry, 1 second. I don't know what just happened. I hope you can see me. In fact, the 5 highest daily tallies for new infections and new deaths have all occurred during the first couple of weeks of 2021. According to data by Johns Hopkins University, COVID-19 has killed 400,000 people and infected about 24 million in the United States alone. These terrible numbers seemed unimaginable at the start of the pandemic just 1 year ago. Health officials around the world are racing to vaccinate as many vulnerable people as possible as COVID-19 continues to spread at record high rates. And with many countries, including the US, facing emerging mutant virus strains that are proliferating quickly. Now for some good news. The light at the end of the tunnel is coming into view. Better months are ahead. We have 2 remarkably effective vaccines and several others in the pipeline. The CDC reports that 31 million doses of the vaccine have already been administered in the US as of this weekend. Experts are predicting that mass vaccinations, warmer weather, a new presidential administration, and a population that is building immunity will start to bring relief as soon as this summer. And while the number of vaccinations lags behind expectations, the Biden-Harris administration has an ambitious plan for ramping up quickly, a plan that the renowned Dr. Fauci believes is doable. Yet there are still so many questions about these vaccines that were produced in record time. How do they work? How can we be sure that they're safe? How can we efficiently and equitably distribute them? Fortunately, our 3 panelists have many of these answers. Together, they can help dispel some persistent myths and set us straight. They represent a multitude of disciplines, which will allow us to explore all facets of the COVID-19 vaccine. They will address the issues from the perspectives of a public health researcher, a clinical administrator, and a policy and community advocate. So let's get to it. I'll briefly introduce our speakers and then they will each present for about 15 minutes, after which we will have plenty of time for Q&A. Dean Porcelli will open the chat after the 3 presentations and audience members can type their questions there. We will also post a more comprehensive speaker bio in the chat for those who would like to learn more about our panelists. Our first speaker will be Dr. Ibrahim Karaye, an assistant professor of health sciences here at Hofstra University in the Department of Health Professions. Dr. Karaye is a physician and an epidemiologist. His research uses novel statistical methods to study disaster epidemiology, the health effects of mass trauma and conflict, health disparities, and global health. He is currently studying the impact of social vulnerability on the coronavirus pandemic using the CDC's Social Vulnerability Index. Dr. Karaye will kick off our presentation by offering us insight into the epidemiology of the COVID-19 vaccine. Our second speaker will be Dr. Mark Jarrett, Chief Quality Officer for Northwell Health. Dr. Jarrett is a physician with an MBA and a master's degree in medical informatics. He is also Northwell Health's Deputy Chief Medical Officer and a Professor of Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dr. Jarrett is responsible for system-wide initiatives in quality and safety, and he will present to us about Northwell's work with COVID-19 clinical trials and offer updates and insights on the federal, state, and health system rollout plans. Our third speaker will be Dr. Andrea Ault-Brutus, Director of Health Equity at the Nassau County Department of Health. Dr. Ault-Brutus has spent the last 20 years working on improving health outcomes and access to quality healthcare for vulnerable and underserved populations. Prior to doing this work in Nassau County, Dr. Ault-Brutus was the Senior Director of the Mental Health Innovation Lab at the New York City Department of Health. And before that, she was a health disparities researcher at Harvard University. Dr. Ault-Brutus will discuss the county's efforts around vaccine education and awareness, as well as what the local community challenges are, honing in on distribution issues, trust, and equity. I'm excited to learn from these three experts. Please remember that we will save questions until all three have spoken. You may want to jot down some notes, and then please be sure to type your questions into the chat when it's time for Q&A. If you've never used the chat function before, please refer to your event confirmation email where Dean Porcelli offered directions. Please also remember to keep your microphones muted. Dr. Karaye, please share your screen now, and then you can please begin.
Thank you, Dr. Kiriakou. It's a pleasure to be here. Okay, let us start with basic terms. What is the difference between coronavirus and COVID-19? So COVID-19 is the coronavirus disease 2019 that is the subject of this pandemic, unfortunately. So SARS-CoV-2 is the virus that causes COVID-19, whereas coronavirus is the family name. So coronavirus is actually a family name. So SARS-CoV-2 is just one member of the family. There was SARS-CoV, which is actually the severe acute respiratory syndrome coronavirus that caused the severe acute respiratory syndrome pandemic back in 2003. There is also the Middle Eastern respiratory syndrome that was caused by MERS-CoV back in 2012. So coronavirus is the family name. So what about an antibody? I think it's actually important that we understand what an antibody is before we delve further. So antibody is actually a protein that is produced by the host, for example, by a human being whenever he's, let me say by the immune system, whenever a foreign body infects the system. So that's an antibody. I will elaborate further. So this is an illustration of SARS-CoV-2, the virus that causes COVID-19. So there are about 29 proteins on the virus, but notable among which is the S protein, that is the spike protein. So this, as we can see, the red protruding triangular spikes, these are the spike proteins. So they are used by the virus to enter the cells. So the spike protein attaches to the host cell and then gains entry into the cell. So I actually see the spike protein as both a source of strength for the virus as well as a weakness for the virus. So because it is used in entering, the virus uses it to enter the cells, but it's also used to trigger immune response. That is to say that it serves like as a fingerprint for the virus. So whenever the virus infects a human body or a system, the immune system identifies the spike protein and initiates a response to fight the virus. So this is akin to the fingers that we have as human beings that could be used for manipulation, which is a positive thing, but it's also a source of weakness, right? For example, fingerprints could be used in forensic analysis to identify the perpetrator of a crime. So it goes both ways. No wonder the spike protein is actually trending. It's actually important. And even in the production of vaccines, the spike protein is usually the target. So now, what is an mRNA? Now, this is a strand of protein in the coronavirus that is that encodes for the production of these spike proteins. So it is a genetic material actually that instructs our cells to produce more of the spike protein. That is how I would explain the mRNA. That's how I can describe it. So now, how does the infection occur with SARS-CoV-2 or coronavirus? So when coronavirus enters the human body, it uses the spike protein to bind to the cells, to bind to the receptors, and then it now gains entry into the cell. So once it enters the cell, it releases the mRNA. Remember that I said the mRNA is actually used, it instructs our cells to produce more copies, of the spike protein. So once it enters the cell, it now releases the mRNA, and then the mRNA now instructs our cells to produce more copies of the spike protein as well as the other 28 proteins of the virus. So the virus will now be packaged and assembled, and more copies of the virus will now be released into the circulation. So technically, the virus uses our cells, it hijacks the cells, our cells, to produce more copies of itself. So it replicates using our cells, technically. So then what happens after this replication? Remember that I said the spike protein is also a form of weakness for the virus. So given that with more copies of the virus, now the spike protein is identified as being foreign, as being alien to the human body. So the immune system will now mount a response to fight the virus, courtesy of the spike protein. So it now creates or produces antibodies, we call them, which are proteins that will now bind to the spike protein. So two things. So the immune system will produce antibodies. These antibodies will now bind to the spike proteins and prevent the virus from binding to the cells and entering into the cells, right? So these are the antibodies here illustrated. So they bind to the spike proteins and then prevent the virus from entering into the cells. But they also tag the virus for destruction. So that is what happens. So as we can see, infection by the virus, let me say natural infection by the virus, could actually mount an immune response, right? Courtesy of the spike proteins. Antibodies will be produced or generated specifically against the spike proteins. And then the virus will now not be able to infect cells, and then the virus will be destroyed. So that's it. So a natural immune response could actually occur because of infection from the coronavirus. How long this natural immunity lasts is still a subject of research. But then think about it. Vaccines could be produced without causing, so we could use a template of the spike protein to generate immune response in a human being without having to infect that host. So now COVID-19 vaccines have been approved in the US. For Pfizer and Moderna are the current two that have been approved for use. And how do this work? So now, because of the mRNA, I previously said the mRNA instructs our cells to produce more copies of the spike protein, right? So the big picture here is the spike protein. If we can produce more of the spike protein, that spike protein can elicit immune response. Our body can generate antibodies to fight the virus. And once we have enough antibodies in circulation, and a memory is now created or generated, whenever a reinfection occurs with a coronavirus, the body will be quick to respond to that. So now there are different vaccines, but I will focus on these mRNA vaccines because both of the vaccines that have been approved, the Moderna and the Pfizer vaccines, all use the mRNA vaccine technology. So, and technically, and this may sound too simplistic, these vaccines contain mRNA, but then the problem is mRNA can easily be degraded by the human system. So because of the toxicity of the human system, the mRNA may not be able to last, right, before it functions. So and for that reason, this mRNA is actually coated in a buttery material. So it is coated and then administered into the deltoid, for example, into the muscle. And once it enters the muscle, now the mRNA will not be released into the cells, into our cells, let's say the muscle cells in this instance. So remember, the mRNA instructs our cells to produce more of the spike proteins. So once this mRNA now enters our cells, it will instruct our cells, just like a text message. So instruct our cells to produce the spike proteins. So and now these spike proteins will not be identified by our immune system as a foreign body. And then antibodies will be mounted, will be produced against the spike protein. That way there will be enough antibodies in circulation, and then a memory will also be created against any potential infection with a real coronavirus. So in this instance, we are generating immunity to coronavirus in an artificial way. So without having to pass through or without having to experience the real infection with coronavirus. So now that is actually how the mRNA vaccines work. So this is all at the molecular level. How does this translate to the public health, at the public health level? So I like this illustration in the Lancet, in Lancet that was just recently published in October of 2020. So the coronavirus vaccine is expected to prevent infection, or to prevent disease, or to prevent transmission. Right? So these are all possible efficacy endpoints of the coronavirus vaccine. So that is what we expect the coronavirus vaccine to do at the population level. So that's the big picture. We may argue about what endpoint is actually more significant for public health. Should it be the transmission, or should it be preventing disease, or should it be the prevention of infection? So that is a subject of debate. But suffice to say, these are all important efficacy endpoints for the vaccine. So the Pfizer and Moderna vaccines, how do they compare? They are both mRNA vaccines, as I had previously described. They are administered in 2 doses, 21 days apart for the Pfizer vaccine, and then 28 days apart for the Moderna vaccine. The Pfizer vaccine requires an ultra-cold temperature of -70 Celsius, unlike the Moderna vaccine, which requires a -20 degrees Celsius. They are both safe and effective, at around 95% efficacy. And then the age requirement, from 16 years and older for the Pfizer vaccine, and then 18 years or older for the Moderna vaccine. So, but there are other vaccines as well that are currently in undergoing clinical trials on different phases of clinical trials. So those that you can see in asterisks, the Oxford AstraZeneca, Johnson & Johnson, and Novavax are currently in phase 3 clinical trials. So, but suffice to say, I want us to understand that we have the RNA vaccines here listed. We have the Pfizer and we have the Moderna that use the RNA technology, right? So that we could see that there are also other technologies besides the RNA technology. We have the viral vector, the whole virus, the protein subunit. How do all these work? Well, as I had previously stated, the spike protein is actually important, right? It serves as the fingerprint for the virus. The human immune system identifies the spike protein as an antigen, as a foreign entity that could be used to mount an immune response. So, so it's specifically targeted. So for that reason, there are different ways we can do it. In the case of RNA, as I have previously described, RNA could instruct our cells to produce more of the spike protein. Well, that is an indirect way. Another way is we could introduce the gene that codes for the spike protein, but this time around, we can use a dead virus, like for example, adenovirus, to transport or transmit that gene, such that once that gene enters the human system, it will trigger the production of spike proteins. That is what the viral vector vaccine does. Then what about the whole virus? Well, we can choose to also introduce a whole virus into the human system, right? Into the human body, we could inject it. But then this is actually inactivated, so it's not the real virus, right? Because we know that the whole virus will also contain the spike protein, and that is the goal. The spike protein will end up triggering immune response. So, but then there is also the protein subunit technology, in which we could introduce the spike protein directly. So that's it. And these are examples of other vaccines that had been used using the technologies listed here. So when we administer vaccines, or when we attain immunity, because as I had previously described, immunity could be attained by either of the two ways: natural infection or vaccination. So sometimes sufficient number of people could attain immunity in a population, and when that is attained, the propensity of transmission of infection from one person to another would actually reduce, because the transmission will be reduced because most people are immune. That is what we call a herd immunity. That is the phenomenon that we describe as herd immunity. So disease is unlikely to spread from person to person. So for example, when we attain, for example, let's say there is a herd immunity of 80% for a particular disease, what it basically means is 4 out of 5 persons that encounter that, for example, virus will not develop the disease because they are immune. In other words, 20%, only 20% of the population will be infected whenever they encounter a virus. So that's herd immunity. It's actually important. So as for the coronavirus, we still don't know precisely what proportion, because it actually differs from agent to agent. So we don't really know precisely what percentage of the population that is required to be immune to develop herd immunity, but it's estimated to be between 70 to 85% of the population. So viruses constantly change through mutations as a way of adaptation. So there are different variants of coronavirus, or let me say SARS-CoV-2 to be more precise, that have been recently identified. And what it basically means, mutations are just transformations. The virus now transforms into a different form. So some changes in the virus. So there is the B117 that was first identified in the UK. Cases have been identified in the US of this variant. As of yesterday, 4 cases had been identified in New York, and around 122 cases have been identified in the US. It is projected that by March, this strain will be the most dominant in the US, this variant. But then there are also other variants of the mutants. The 1351 was identified in South Africa. We are still yet to record a case in the US. There was the P1 that was identified in Brazil. We still also don't have a single case in the US. So now, what do these variants mean? Do they mean increased virulence, increased severity? No. Based on what we know about these variants, they increase, these mutants actually have higher transmissibility. That is to say, the viruses are more likely to spread from one person to another. And but there are no evidence. There is no evidence at this point that shows or that indicates that these variants result in a more severe infection or in a higher mortality. But the transmission rate is actually higher with these variants. That is what we know about this. So this is a map of the B117 mutant that has currently been identified in the US with 4 cases in New York. So it's a pleasure contributing to this platform. Thank you very much. Thank you.
Great, thank you so much, Dr. Karaye. I really appreciate your insights and detailed information on this. And we'll have an opportunity to ask questions after we've heard from our other 2 panelists. And also, I just want to make sure everybody knows that they will have access to this recording and all those slides, so you'll have Dr. Karaye's information, contact information as well. I'd like to now welcome Dr. Mark Jarrett to provide, some information on the topics I mentioned before about what's happening with clinical trials and Northwell's role.
Thank you very much. And it's hard to follow an excellent presentation such as that. I decided to make mine PowerPoint free simply because of the fact that some of the areas I'm going to be covering changes from the state or the federal government almost on an hourly basis. So anything I produced yesterday probably would have been outdated today. First, on the issue of clinical trials, during March and April in the first spring, the spring surge, Northwell did participate in a number of clinical trials with some of the drugs such as remdesivir, et cetera. One of the problems is that at that time, we had no knowledge of really how to treat the disease appropriately. Just to give a proportion, we have 23 hospitals, but we had over 3,500 patients with COVID in the hospital at that time. And at our peak, we had 800 people on ventilators. So, we were throwing everything but the kitchen sink at the patients and, probably not using all high science. As you remember, social media, the internet, even CNN every day was saying this seems like it works, that seems like it works based on 30 cases from France or 20 cases from Italy. And that's not the way to medically approach it or scientifically approach it. So we did do some trials. They were hard to get people to sign on to because often there was the compassionate use clause and people did not want to go in a placebo-controlled trial because they were afraid they were going to die, not that we knew whether the medication would help. And I will say some of the things we did probably not only didn't help, but might have perhaps even increased mortality a little bit. So I think it gets back to the issue that we really need to do scientific trials. We are now looking at some new trials because we have a resurgence. During the summer, we were not really involved with trials because of the fact that the disease prevalence was so low, thankfully, that it would have been difficult to get anybody into a trial and get enough patients. But now we're back and we are doing a few trials again. But on a national basis, we have to start taking the attitude that it is safer to do a trial than it is to just sporadically try things and see what works and what doesn't. because many of the things that people had impressions were working were not working. And I'm going beyond hydroxychloroquine. So it really, there are a lot of things that we saw. So that clinical trials right now, as I said, we're doing a few. We may even do one of the new vaccines that is still waiting trial. That's where we're going. Now, to put this all into perspective, as was said originally, today marks a hallmark of 400,000 people who died, and that's people who died from COVID. Especially in the spring in New York, we probably lost maybe close to 100,000 people because they didn't come in for proper care. People were afraid to come to hospitals, surgeries were closed. This was a real major problem. So when we talk about mortality as a country, we probably have to reflect that if there are 400,000 people died of COVID, there may be another 250,000 people who died that shouldn't have died of normal diseases that we can treat. Simply because, as you look at California, ICUs are overcrowded, people are not going to the ED, etc. So we need to put these numbers in perspective that it's worse than it actually is. Now, in terms of vaccines, you heard the science behind it. It is good news. It is a true miracle of science that basically in 1 year, we have vaccines to treat this disease and prevent this disease. Doesn't mean we can go back to normal. We're going to have to socially distance and wear masks for probably all of 2021 till we achieve herd immunity. But the reality is we're still being able to protect especially the most vulnerable at this period of time. And that's really something, you know, that if those of us who remember the early days of HIV, we went so many years before we had anything that could treat it. And now we have something, we have medications that can treat, like monoclonal antibodies, we are remdesivir. We know now that steroids works at certain points in the disease process, but more importantly, we now have these vaccines available to us. Now, the rollout has not gone smoothly as we would like. Again, wearing my chief quality officer hat, we frequently see things don't work the way we expect them to work. You know, to quote the military, battle plans work until the first bullet is shot. Well, it's the same type of thing here. And again, if we put, you know, it needs to be better, it should have been better. However, if we think about it, we've already immunized about 4.5% of the United States population. May not seem like a lot, but this all started 5-6 weeks ago when we got the first shots. So this really is not terrible news, but not what we want to hear. It should have been closer to 20 million by now. So what do we see? And I'm not going to get political about who did what right. The government, federal government, did push the pharmaceutical companies to develop vaccines. They paid them to start manufacturing them before they were even approved, which had never happened before. And that cost the federal government billions of dollars, but it allowed the companies to be ready as soon as the emergency use authorizations came through to be able to distribute the drugs. And that has probably saved us 3 to 6 months, quite frankly, because developing these drugs and producing them in large numbers is not easy. These are biological agents, so to speak, and it takes a long time to produce them, get it right, get it FDA approved, both for the manufacturer as well as the use of these drugs. So this, again, was a good move. They also used the military for logistics. And if there's one thing the military is good at, it's at logistics. They can move, you know, a whole bunch of tanks that weigh, you know, 10 tons across the world in a matter of days with all the supplies. What really kind of fell apart was this last mile. And that's the hardest part of the whole thing. It's when it's gotten to the places that are going to start distributing it, whether it be county health departments, whether it be Northwell Health System, whether it be the New York City Health Department. From that point to the patient's arm are the most difficult things. And again, it's been a learning experience. So in the beginning, we had to get the plans. We could not develop the fact sheets, contraindications, all those things till we got the emergency use authorization. And then A week later, we were giving the vaccine. So it was a rush to do that. There was the question about allergies and anaphylaxis right from the beginning. So this is a process that is not the same as people getting flu shots. Well, flu shots, you all line up in a line, you get your, you register, you get your information taken, you get a flu shot and you walk out. And, we talk about using this vaccine in pharmacies. Well, the last time I walked into my CVS, they had no place that you can socially distance to wait online. I mean, if there's a long line waiting for a drug, picture for this, even with appointments. And because it is a new drug and it is still experimental, it's only got an emergency use authorization, people have to sit for a while and, for at least 15 minutes to make sure they don't have a problem with anaphylaxis or severe allergic reaction, which there have been reports of, very few, but reports of. And if you have a history of severe allergies, you may have to wait 30 minutes. Well, that means you have to socially distance, you have to have somebody who's there watching them and somebody who can respond with an epinephrine pen and then call 911 if you have a problem. And quite frankly, I don't see that working in the soap aisle of CVS in aisle 3. So what we've really recognized now in the first couple of weeks is, yes, for some rural areas, perhaps for some very underserved areas to meet equity, we may need to have little pods. But the best way to work it in urban and suburban areas is to develop large distribution points, we call pods, points of distribution. So examples of that might be what's going on at Jones Beach, what's going to be going on in New York City at Jacob Javits Center, where you can have 50 people giving vaccinations, have a large area with the right number of people watching people for observation, and do this in a way that you can do thousands of patients a day, not hundreds of patients a day. So I think we've kind of altered our thinking about it. Now, when at one point I want to bring out, when I said the drug's experimental, that means it has not met a full FDA approval, okay? The full FDA approval will require about 6 months because it's long-term follow-up. That's the rules, that's the way it is. We use emergency use authorization sometimes, for other situations. And, we all feel it's comfortable. As a physician, I've gotten both of my doses. I would not give it to myself. 2 of my children are physicians, one son, one daughter. They've gotten their vaccines. Clearly, we feel very comfortable that these are safe, all right? No drug has no side effects, but we feel these are safe. So the term experimental only refers to the fact that it hasn't gotten full FDA approval, which may occur, let's say, during the summer, okay? But that does not mean people shouldn't take it. Vaccine hesitancy is a real problem. I would say vaccine hesitancy is more of a problem in communities of color. They look back at the history in America of some of the experiments that were done and feel quite frightened about it. I do not blame them. I think the fact that we have people of color from different communities getting on TV now, accepting their vaccine, I think is the right answer. I'm almost guaranteed almost none of you on this call remember back with the polio vaccine. It was given to small children, but it wasn't given to teens, even though they got polio. Teens didn't want to take the vaccine. So they actually got Elvis Presley to go on Ed Sullivan's show, take the vaccine live, the shot live, and the use in teens went from 15% to 80% in a matter of about 2 months. So we need to do that because unfortunately, people of color are dying at 2 to 3 times the rate of white people from this disease. Why that is, we are not sure. Is it pre-existing conditions? Is it something? We don't know that answer yet, but that's the reality. So we've got to figure out a way to get this drug out equitably, which brings up the issue then of priorities. So as you know, the first priority in most of the country, as recommended by the CDC, was give it to healthcare workers. This was a little controversial because some people believed you should have given it to the elderly first, or maybe even to the nursing homes patients first. And as you know, also in Florida, they gave it out to the older people first and gave it to healthcare workers at the same time, but did not prioritize the healthcare workers. I think the reason why it was felt by the CDC and why most of us agreed with the healthcare workers was not because we were healthcare workers. We did prove during the spring in New York that with appropriate personal protective equipment, PPE, healthcare workers were protected. They did not, in fact, we demonstrated with an antibody study at Northwell that they actually had a lower rate of conversion with positive antibodies, meaning they had the disease, than the community. Probably because they were so careful, because they saw how the horrors of the disease, and the PPE protected. So then you'll say to me, well, then why should they get it if they're protected? Because they were protected in the hospital. They were not protected in the community. And therefore, they might have gotten it in the community instead. And if they get sick in the community, as it's widespread now, they're going to have to be quarantined for 14 days. Well, if they're quarantined for 14 days, they cannot take care of patients. And it's not that every single person in the hospital was critical to taking care of patients, but if you think about critical care nurses, intensive care doctors, emergency room physicians, surgeons with special skill sets, you think about the dietitian who brings the tray into the room of the patient with COVID. You think about the environmental worker who works in the ICU, the COVID ICU, and is cleaning those rooms and exposed. Those patients are essential to the hospital and to caring for patients. And we could not afford to have them get sick. It's kind of a general rule of emergency management. You must protect the responders first, because if you don't have the responders, you have nobody to take care of not only the COVID patients, but the patients who come in with heart attacks, strokes, need emergency surgery, neurosurgery. So that was the rationale for doing it. And I don't think it was a wrong decision. In New York State, we quickly moved simultaneously to giving on the second week to the long-term care facilities, the nursing home patients, which, as we know, were the most vulnerable, and in the spring made up 40% of the mortalities in New York, of just the people living in the nursing homes. So we quickly shifted to that. I think as they saw vaccines were not going out fast enough, the CDC, and looking at also what the experience in Florida, one or two other states, decided to open it up to people over 65 with immunocompromised, et cetera. And the governor was only going to do 75. That was great, except the problem is there are 7 million people now in New York State out of our 19 who meet the criteria to get vaccinated. And our supplies to the state are not huge. And in fact, we don't, we're all worried about it. So that's a problem. And it's a problem because people are trying to schedule themselves. People are scheduling themselves and now finding out they may not be vaccinated when they need to be scheduled, when they have their appointment. And this is very frightening to people, because it's a good thing we got lots of people who want the vaccine, but it's a bad thing we can't deliver it. We've set expectations a little bit too high. People want to be vaccinated today. They don't want to wait a month, which I certainly understand. So we need to do a little marketing and social engineering around this so we do not get into problems. What I expect is the current group of 7 million, with a little bit of luck, we will have done by April, and then we can move on to the rest of the population. And we also have to remember that despite being vaccinated, everybody has to wear masks, wash their hands, and socially distance. Because what we have not proven to this point, we've proven that the vaccine is 95% effective, as was just said before, for preventing disease, but it does not mean that you cannot spread disease. You may become an asymptomatic carrier for a short period of time. So in order to prevent spread of disease until we reach herd immunity, we need to continue following these things. So it really means people can't change their lifestyles even if they get vaccinated. It certainly makes you feel better, but you can't change your lifestyle. So we have to get that message across. There is a little concern now that we have that perhaps the federal supply of second doses that was supposedly being held back has not really been held back. What we are doing at Northwell is taking the attitude that as we get vaccines, We are keeping second doses based on how many first doses we gave, because we do not want people not to be able to get their second dose. That is the way the drug has been proven to be 95% effective, not maybe 50% effective. The key will be, hopefully, as mentioned before, is when the Johnson & Johnson vaccine is approved, hopefully maybe around the end of February. That's a single dose. That will make our life easier, because we've also had to put in safety things. You come in for your second dose, we have to make sure that you're getting the right drug. You're not getting the Moderna if you took Pfizer first, or vice versa. So we've put in a lot of safety factors, different lanes, other things, questions, to make sure that we're giving out the drug safely and people are getting the right drug. In terms of drug wastage, we've had almost no wastage. I mean, I'm sure there's a couple of single doses that might have been wasted somewhere along the line. We've given approximately 70,000 doses already, but I think you can probably count it on one hand. And the reason for that is we have a standby list, so that if as the end of the day goes on, we see we're going to have more supply than we have people booked, people have canceled, we will call our standbys, or we will literally move the drug to another site which has people, because we do not want to waste any of the drugs. It's been a challenge. I think we can all meet the challenge. I think, unfortunately, everybody has to recognize not everybody can get the drug at the same time. So it will take time to go through the population. But I think it is something that we learned a lot of lessons from already. And I think we will be making even more progress over the next 2 or 3 months. And hopefully, eventually, at some point, maybe at the end of the year, get much closer back to a normal life. I'm going to stop at this point and thank you for listening late in the afternoon. I know you all work hard during the day, and appreciate it. Thank you.
Thank you so much, Dr. Jarrett. Really appreciate it. I see that some questions are popping up in the chat, but as I mentioned earlier, we're going to wait and hear from our third panelist first, and then we will absolutely get to the questions in the chat. So with that, I'd like to invite Dr. Ault-Brutus to please share her screen, and she will talk to us about really what's happening at the county and the community level.
Great, thank you. Okay, sorry. Okay, hello everyone. Thank you so much for inviting me to be a part of this esteemed panel. Great presentations prior to me, and actually some of the points I was going to discuss today were covered previously, but I will go a little bit more into detail. So I'm going to be talking about how we're addressing COVID-19 and just getting vaccines out to communities of color. And just want to talk first about some of the activities that we're doing here within Nassau County as part of not only the Department of Health, but our other agencies throughout our county. And you know, focusing on education and raising awareness, not only of the vaccine, but of COVID in general. You know, we started back in April, where we saw immediately, not only in Nassau County, but across the country, how COVID was disproportionately impacting communities of color. And so one of the things we were able to do early on was partner with our federally qualified health centers, so particularly LIFQHC, to provide COVID testing in communities of color. And when we had these testing sites throughout the county, we took that opportunity to educate individuals about COVID-19. And we did this when we did food distributions also throughout the county, clothing drives, PPE, utilizing all these opportunities to educate people about COVID, to prepare them for when the vaccine comes down the road. In addition to that, we conducted numerous webinars with local schools, like for example, what I'm doing today, with civic organizations, faith-based organizations, countywide, just to get the word out about the not only COVID, but also the vaccine. And then also sharing information utilizing our website, direct mailing, SMS texting, and also partnering with our offices with Minority Affairs, Hispanic Affairs, and Asian Affairs to reach particular specific groups within our communities across the county. And as many of you know, we also have the 7-day-a-week COVID hotline available by using language access to be able to speak to many people in different languages. And also, currently, we're partnering with, actually, we're participating in the Long Island Region Health Equity Task Force, which is part of the larger effort that the state is doing to engage communities of color and help us to guide their plans for rollout of the vaccine and also implementation of that rollout. So as been mentioned previously, there has been a number of challenges with the rollout that we see immediately. The first challenge is what Dr. Jarrett mentioned earlier, is the supply issue. We have a huge demand for the vaccine, not only in the white population, but in communities of color, actually, believe it or not. Even though there's a lot of mistrust of the vaccine, which I'll go into in a little bit, we actually are seeing a high number of individuals, especially seniors, who are interested in getting the vaccine. Personally, my father-in-law, for example, he had COVID early on, right? Actually, both my in-laws had COVID early on in April of last year. And unfortunately, they have seen a number of their friends get COVID. And unfortunately, a number of their friends have died from COVID. And so I do think that within particularly the senior population, there is this change in mindset of taking the vaccine. And I'll go a little bit more into that a little later. But we see a digital divide. A lot of the appointments to get a vaccine are online. And this is especially difficult for seniors who are homebound, who are not technologically savvy, whose children or grandchildren do not live with them. So these are some things that we need to think about within the county and with the state as to how do we get our seniors and some of those who are not able to get online to figure out ways to get them access to these vaccines. And these conversations are taking place currently. And then there's the mistrust of the vaccine in communities of color, which is a huge mistrust. And as Dr. Jarrett mentioned, there are real reasons for this mistrust. I have some pictures here of examples of why this mistrust exists. Starting in the bottom corner, where slaves were often used. This is a picture of the father of gynecology, who used a lot of slaves to test various techniques that are used today in gynecological purposes. But then you have history of sterilization, you have the issue with Henrietta Lacks, with using her cells illegally without her knowledge, and now is used throughout medical schools. And then obviously you have Tuskegee, the history of Tuskegee, which was a sanctioned US experiment where they withheld treatment for those who developed syphilis. And a lot of us in the United States remember these atrocious acts that were committed against us. And the legacy of these, even though there's protocols in place to ensure that these types of things never happen again, even though there's been recent news about sterilization of undocumented mothers at the border, there are protocols in place to ensure that, at least in research, these types of atrocities do not happen again. But then you have current issues within the medical system. You have the fact that Black mothers are more likely to die when giving birth to a child in the United States more than any other racial ethnic group in the United States, including in Nassau County. And then you also have, across New York State as well, and you also have rates of infant mortality higher amongst Black babies compared to white babies. You have a history of Black individuals not only getting cancer at higher rates, but also dying from cancer at higher rates. You have a history of Black individuals getting HIV and AIDS at higher rates. You have history of us getting chronic conditions, other chronic conditions at higher rates, like heart disease, diabetes, asthma, obesity. So you have all these things happening in the midst of the pandemic of COVID. So you have the COVID pandemic, but you also have the racism pandemic as well. That's been historical since the beginning of this country. It is our original sin. And so you have these two pandemics happening at the same time. And it's no wonder that now there's this level of mistrust in using the vaccine. But we also have to remember that, unfortunately, because of this history of racism in this country, we, because of social determinants of health, are more likely to get COVID and also are more likely to be hospitalized for COVID, and therefore also are more likely to die from COVID. And therefore we are met with this decision we have to make where, do we trust science, which has been historically not been in our best interest to do so? Or do you see how things have changed over time? Even though things need to be improved dramatically in the United States, do we risk our lives if we get COVID? And I think one quote that I often think about is the nurse who first got vaccinated, the nurse from Northwell in the United States. And she said that, when she decided whether or not to get the vaccine, she thought about, well, what will happen if I get COVID? And she decided she trusts the vaccine over what could happen to her if she gets COVID, because there's so many stories of relatively healthy individuals who will still die from COVID. So she decided to put her trust into the vaccine. And personally, that's where I put my trust in as well. And that's the message I tend to communicate to others when talking about the vaccine. There's been a lot of safety measures put in place, obviously, so to ensure that the vaccine that's being rolled out is safe and effective. And thankfully for the 2 vaccines that we have, they are roughly 95% effective. And so far, we've seen very little side effects from the use of both vaccines. And so in closing, I would just say that, the good news is that I am seeing a change in people's attitudes towards using the vaccine. A lot of these attitude changes is happening amongst our seniors. So hopefully over time, we will see the younger generation of individuals, especially in communities of color, start to change their minds about the vaccine. But obviously, one of the most pressing issues we need to deal with right now is the supply issue. Hopefully and not to get political, but hopefully with the new administration coming into place, we do see an increase in the not only the production of the vaccine, but the rollout of the vaccine. But I think also to ensure that there's an equitable distribution of the vaccine, that we work hand in hand with our communities, trusted community partners, in ensuring that especially those living in communities of color get access to those vaccines. It's going to be a long, hard road. It's not going to be easy, but I do believe at the county level and the state level, we're putting what's needed to be in place to ensure a more successful rollout down the road.
Excellent. Thank you so much for that poignant, although hopeful message. Really appreciate the remarks from all of our panelists. So we do have a bunch of questions already in the chat. We now have, about 20, 25 minutes. And so we'll try to get to as many of them as possible. And for those that we do not get to, I do promise that I will have our panelists respond, and we'll email them out when we email the presentation. So everybody will have their questions answered. So let's see, the first question had to do with whether or not if someone gets vaccinated, they need to quarantine. I think that might have been related to the fact that, we did talk about how, even after you have the vaccine, you might be able to still shed the virus, but I'm not sure if maybe Dr. Jarrett wants to respond to that. It doesn't seem like it would put other people at risk, but go ahead. Yeah.
We've had a couple of cases where coincidentally people got vaccinated with their first shot on Monday and Wednesday came down with COVID just because they were incubating it. We don't test people beforehand, and they were incubating. And then they had to follow the normal quarantine rules. And if they got monoclonal antibodies, they have to wait 90 days to get their booster. If they didn't, then probably about 3-4 weeks after when they're asymptomatic, they can get the booster. If you've already had it, and the 2 vaccines, and you develop COVID, which would be in a very minor number, you're going to have to be quarantined. The real question is going to be, they're talking about airplane travel and having to get tested. If we pick up asymptomatic virus in your nose, 3 months after you're vaccinated, we don't know yet what that really means, to be honest. Most likely it means you're not going to get sick, but it means you might be carrying the virus and we don't know that. And then you might have to be quarantined for a period of time.
Okay, thank you. I think the second question was related to that also, in terms of people getting COVID in between the first and second, and do they have to, wait? And you said for some, they may have to wait longer, and for others, they may not need to wait. Okay, great. What about this question? And I don't know if Dr. Ault-Brutus, you want to start with this. You started to allude to it, but somebody said, what about elderly or disabled persons who are homebound and unable to get to a place where the vaccination is being provided? And any of you, but what kinds of plans are in place for those folks that are not in nursing homes but can't get out to the doctor?
Yeah, and that's a really good question. And that's a question we've been thinking about here at the health department. And not only in the health department, but also partnering with our Office of the Aging, which is out of the Department of Human Services. And actually, within the last couple of weeks, we were really thinking about how best we could reach out to our seniors. And then unfortunately, we received word from the state that they didn't want us to, and I may be over-speaking or saying too much, but they didn't want us to be focusing on the seniors and they will handle it. So unfortunately, we are in this position where we are kind of building the plane while we fly it. Unfortunately, where we are coming up with plans, but we have to be beholden to what the state wants us to do. And so I know that we had plans in place to do more direct outreach to not only senior centers where the state's day programs, but also working with churches and community groups to ensure that our elderly are getting the vaccine. But unfortunately now there's been a shift in guidelines as to whether or not the county will be involved in that. And hopefully that will change once again. I think we know our population better than anybody else at a much higher level. But that's a great question, and it's something that we are really trying to figure out. But unfortunately, we are building the plane as we fly it.
Understood. Thank you. I think this next one perhaps for Dr. Karaye. So the question is for those who have the antibodies, do they need to sign up immediately for the vaccine, or perhaps they should wait?
Okay, so those that already have the antibodies against the coronavirus, so can you come again? So they have already been infected and they had demonstrated having antibodies in their system for coronavirus. Is that correct?
That is.
What's
And
the
the question is, why should they still get the vaccine, which we know they should do, but maybe you can explain why.
Okay. So thank you. So the problem is, well, the infection with the virus we know elicits immune response, as I had previously said. But then we don't really know precisely for how long that immunity will last. Studies have shown that reinfection with the coronavirus is rare within 90 days after the first infection. So within the first 90 days, data has shown that it is unlikely for a person to be reinfected again. So what it basically means is after 90 days, there is a likelihood that reinfection could occur. So, and that is actually not long. I mean, 90 days within a span of about 3 months, right? So, but that is why we need the vaccine, because the vaccine, especially after having 2 doses, is actually expected to provide a longer lasting immunity, a longer lasting protection from the coronavirus, from SARS-CoV-2, to be more precise. And that is why we need the vaccine.
Okay, good. Thank you. And there were a couple of questions related to that. So I think that's something that people were really curious about. Here's another one, maybe for Dr. Jarrett. Is it unusual to develop side effects 7 to 8 days after vaccination, like redness and itching in the arm where you're vaccinated and where it was administered?
Local site irritation may occur a week later. Most systemic things like having a fever, muscle aches, etc., go away in the first 3-4 days. Again, this is a new vaccine. It does hurt longer, I can tell you that personally, in the arm than most other vaccines I've taken over the years. But if it's more than 4 or 5 days later and you haven't had anything before that, one would wonder if it's due to something else. Remember that even in the studies, placebo patients who did not get the actual vaccine in the studies that got this approved, had some symptoms a couple of days later, a week later, similar type things, even though they never really got the actual drug. If you're at all concerned because a week later you have something that's not going away, speak to your physician. that is the best thing to do.
Great, thank you. Any of you, maybe for any of the three of you, any knowledge about research on vitamin D and COVID-19?
I will tell you that from my looking at the data, there is no hard data on vitamin D or any of the other supplements. Many supplements were tried during the spring and really did not pan out. I think, again, like anything else, as I said earlier, if we're thinking of doing these things, we should do controlled studies. We unfortunately have enough cases, and that's the only way to tell. And, you know, we don't know what the side effects are. It's, you know, everybody thinks, well, vitamin D won't cause a problem. Why not just give it? But we don't know that. This is a very unusual virus. It is spread quickly. It's getting all these variants very quickly and genetic mutations. We don't know enough about it. So I would say, I would stick to the, you know, staying healthy, keeping a good diet, take your normal multivitamins if you need to, but I would not use vitamins for treatment.
Great, thank you. Dr. Karaye, how about this one? Can you confirm whether or not the vaccines have any effect on the COVID-19 mutations? Will they work on the mutations?
Okay, so based on the available knowledge, what we know about the vaccine, it does work even for the mutants, even against the variants. Yeah. So regardless, because the mutations on the spike protein have not been significant enough to alter the antibodies, the structure of the antibodies that fight the virus. So yeah, so the vaccine has been shown to be effective even against those mutants.
Excellent.
Sorry, Dr. Kiriakou. I want to build on just to highlight again on the previous question that was asked regarding immunity. I think one reason that we should also take the vaccination seriously is Moderna had recently released data in highlighting that it's likely their vaccine could even confer immunity for at least 12 months. So which is actually longer than the 90 days that we expect to get, the passive 90 days that we get, that we hope to get some immunity after natural infection. So when we weigh both, I think it's actually better that we take the vaccine.
Good, excellent. Immunity from the vaccine seems to last longer than natural immunity.
Yeah.
Dr. Ault-Brutus, perhaps you could take this next question, which is about how difficult it is to get an appointment to get the vaccine, right? I'm sure many of us have experienced that. I know I spent like 6 hours on the phone trying to get my mother an appointment. What do you recommend to people who might call into the county? Perhaps you're getting, you know, complaints or concerns about, you know, where to go, how to figure it out, how to get an appointment and that.
Yeah, I mean, I know a lot of people also have been expressing that same level of concerns, and we're hearing it on a daily basis, these concerns. I mean, the main thing I would say is continue to inform the health department about your concerns, but the biggest rate limiting factor is the fact that we do not have the supply. So the reason why people are having the difficulty getting an appointment is because there are no appointments available because there's no supply. And unfortunately, we're also hearing cases at other facilities, not to mention their names, but other parts of Long Island and even in the state, where people are making appointments, they have an appointment, and then unfortunately the site doesn't have supplies. So that is the rate limiting factor. Hopefully with the new administration, we'll get the supplies and then we can start, just really getting people more appointments. I mean, the other issue that we didn't bring up, which is also staffing shortage. I mean, thankfully we have a lot of volunteers who asked to be a part of these pods to help us with dispensing the vaccine. But my hope is that once we get more supply coming in, and hopefully we'll have enough staff to get more people signed on. But unfortunately, that is going to be the struggle until we get the supply in. But the one thing that we at the health department also are doing, again, is working with civic organizations, working with churches, and they're letting us know that they have this list of people who want to get the vaccine, and so we're not forgetting about those different organizations who are reaching out to us already. And so once we get more supply, we're really trying to work with them to figure out ways to get them the vaccinations. And also I noticed someone else had a question about getting the vaccine at an urgent care facility due to shortage. And I could speak to that a little bit because I've worked in pods already. And one thing I would say is that there are medics, at least the ones that we do at the health department, we have medics on site in case something were to happen to you while you're waiting for the 15 minutes after getting the vaccine. So I would imagine that in an urgent care facility, they also will have the proper staffing on site to ensure that if something were to happen to you, they could take care of you immediately and then call 911 if needed. And then another question I think is to me, I'm sorry not to not to look at these questions, but I see them right now. I'm happy to talk to high school students. I've already been meeting with high school students who've requested me to speak to their school. So hopefully we could give our information to people who are interested in having any of us, well, I'll speak for myself, to talk to your high school.
Excellent, thank you. And yes, we absolutely will share contact information if that's okay with you. And thanks for looking ahead at some of those questions. I see that one of the questions that you responded to, part of it, I'd like to pose the other part to Dr. Jarrett, and that is somebody is asking whether or not there should be concerns about getting the vaccine at an urgent care facility or perhaps at a pharmacy because of the need for storage, ultra cold storage. So are we worried about, perhaps, errors due to storage problems?
Well, and that's an excellent question. Certainly for centers like, a pharmacy, or let us say an urgent care center, probably using the Pfizer drug, which is the one that has to be at -70, is probably not going to be easily doable. There's a lot of logistics behind it. The Moderna vaccine, however, can be stored in a regular freezer and it be kept in at a decent temperature. The key there is to have what is required actually by the Joint Commission anyway, if you're a hospital or a doctor's office, is that the temperature be monitored 24/7. So if there was a power outage in the middle of the night and you didn't have a generator, we would know, yes, that was wasted, but it's now inactive. You certainly wouldn't want to give it to somebody thinking that it wasn't sufficient. And again, I think these sites will be helpful, but they will never be able to do the volume we need. I think they're adjuvants. I think urgent care centers that are in neighborhoods where it is difficult for people to travel, I think will be helpful. Same thing with your local pharmacy. They will help in what we call micropods, but the real key is going to be these large pods, for everybody.
Okay, good, excellent. Someone is asking about how are we going to determine whether or not we need to get revaccinated? And I'm assuming that she's asking this like annually. Will there be a test? Will we be looking for the return of symptoms? How do we know?
I will say if I knew that, I'd buy a lot of lotto tickets. They're worth a lot of money. The science is being studied, quite frankly. I'm joking, but the science is being studied. We don't know the answer yet. We are making the assumption based on the mutation rate that we're seeing already, and making the analogy of the flu. This virus is going to be around in the world for a good while. Maybe not exactly in this form, maybe in another variant. And based on that, we think that it probably will be necessary, at least for the near future, the next couple of years, that at least once a year, probably have to take a booster. And much like a flu shot, it may have some differences in it to account for the new variants that are coming out in the winter season each year. So I think that is practically what's going to happen. One can never know. Viruses can be very strange. We look at this, the original SARS-CoV-1, which was unfortunately so fatal, but thankfully just disappeared kind of on its own. So we don't know what's going to happen, but the scientists all over the world are studying this right now.
Thank you. I was going to ask a question about kids, but there's a question in the chat about teenagers. So somebody is saying, since there's a limited supply of vaccines, do you think high school seniors, like the person asking the question, who does not have any underlying illnesses, should wait before seeking the vaccination? So what are your thoughts on that? I know right now that group would not be in the priority group, but once it's available, should teenagers be getting it? And, we don't have, I think we have information from 16 or 17 up in the clinical trials, and we're only now looking at those younger, but what are your thoughts on that?
My thoughts in general across the board is that if your group is eligible, I say go ahead and get the vaccine if you're eligible to get it. I don't quite see the point of waiting. I mean, if the science is there, which we see already with, those who are 17 or up, I think it's 16 or 17 or up. But if the science is there showing that it's effective and safe for your particular group, and the CDC declares your group as eligible to get the vaccine, and I completely advocate for them getting the vaccine, but I'll let others chime in.
No, I agree 100% with you. Once they hit the criteria for eligibility, they should get it. And there are studies now going on looking at children younger than that, because I expect that even grade school children will eventually be receiving the vaccine. Probably not till the fall, but to achieve herd immunity, we have to reach everybody, because even if children don't get sick, they can be asymptomatic carriers. So really, to achieve herd immunity, we're going to have to really hit 75 or 80% of our whole general population.
Okay, good. Thank you. There's another question here. I think it might be the same person, but asking again about quarantine after getting the vaccine. And I just want to make sure we're really clear that there's no recommendations for quarantine after getting the vaccine. It's only, certainly if you've been exposed to COVID, but there's no exposure risks associated with the vaccine, correct?
That is correct. It is not live virus that you're getting. You cannot, it's like a flu shot. You can't get the flu.
Excellent. Thank you.
And I'll just add that, everything correct. And just that you have to continue to wear your mask and everything, social distancing, because you still do not know. You could get the vaccine, you could get the virus even within the first couple of weeks of having the vaccine. But even the other thing too is that we still don't know yet if you could still transmit it to somebody else. So that's the other thing too. So we still have to take these safety measures into consideration.
Absolutely.
Yes, I also want to highlight that, as had been stated by Dr. Jarrett, it's an RNA vaccine, as I had also stated, right? So the RNA instructs our cells to produce protein, and specifically the spike protein. Well, there are about 29 proteins in the coronavirus, right? So we need additional proteins, as well as we don't have the complete virus. So it's only a component, only one protein that will end up being produced. So there is technically a zero risk of active COVID-19 infection after getting vaccinated with the mRNA virus. So there is no logic behind quarantining because one has been vaccinated with the mRNA vaccine here.
Excellent. Thank you. So 2 questions related to reproduction and breastfeeding, pregnancy. Are there concerns, and what do we know about the risk of vaccines causing sterility or having any kind of negative effect on pregnant or breastfeeding women?
At this point, the studies that produced the emergency use authorization did not include pregnant women or breastfeeding. As very common with most new drugs. I mean, those really shy away. However, the Society of Maternal Fetal Medicine, which is concerned about the baby, as well as the mother, and the American College of Obstetrics and Gynecology have both recommended that women who are pregnant receive the vaccine and women who are breastfeeding receive the vaccine. On the former scale, it's because of the fact that women who are pregnant, if they get COVID-19, have a higher risk of severe disease and perhaps even of death. So therefore, they feel it's far outweighed. On the breastfeeding, they see no indication why this is a problem. So although it was not studied, although the CDC has said, leave it up to, to the doctor and the mother, these societies have said it. Our recommendation has always been that if you have that type, if you are pregnant or you are breastfeeding, speak to your obstetrician, speak to your pediatrician, see what their feelings are. Almost all of them are following the society guidelines, and therefore we do not expect the problem, and there's no theoretical reason why sterility should occur.
Okay, good. Thank you. A couple more. So if you are someone who carries EpiPen, perhaps for an allergy to bee bites, are there any contraindications to taking the vaccine?
If you carry an EpiPen for it, you should, and you know it's just bee bites or it's just peanuts, you should probably let the people know when you're coming in, and you will be observed for at least 30 minutes then, because you're at higher risk of anaphylaxis. If you have multiple allergies that you require an EpiPen for, then that's a discussion with your doctor, and you may even want to see your allergist first and make a decision whether you should get the vaccine or perhaps wait for the next vaccine, let's say the Johnson & Johnson, where it seems will probably be less likely, it's just different, and the fact that you only have to take one shot, which puts you at less risk.
Okay, thank you. Someone is asking, why is it that the antibodies would last longer from the vaccine than from the infection itself? Anybody want to take a shot at that?
Actually, it goes against the normal thing that happens. Generally, we develop better immunity with natural infections than we do with vaccines. We have to give boosters of vaccines. Yet, if you had chickenpox when you were a kid, you probably never get chickenpox for the rest of your life. So it's a little different, but we're not sure why. But again, this is a very different virus. We also are aggregating the immunity, saying everybody's the same. A lot of people have very mild disease, low-grade fever and feel achy for a day, and then they feel fine. Others, get more infection. They can lose the sense of taste and smell. They get other symptoms. It really makes it for 2 weeks. And then you finally have the group that winds up in the ICU, intubated and survives, but has really had a huge problem. We've never really looked at reinfection in those groups. Reinfections have been very low in general. So it could be that it'll turn out that natural immunity will protect you for a year for most people. We don't know that, and we can't take the chance.
Okay, good. Thank you.
I also agree with Dr. Jarrett on this. So it could also be because the SARS-CoV-2, especially the spike protein, could actually undergo conformational changes at the molecular level. I wish that the spike protein would have a single conformation, a single structure, such that once the body naturally develops that antibody or mounts an antibody response, that will be forever. But the problem is, with time, there are two conformations to the spike proteins. So if an antibody is produced against the spike protein in one form, it may not be effective once the spike protein changes another form. So there are two conformations. So now in the development of the vaccine, and that is why relatively we have the development of this vaccine has actually been relatively fast, because it has been studied for decades, since after the SARS, and then since after the MERS epidemic in 2013. So studies have been done, investigations have been done to stabilize the conformation or the structure of the spike protein in the vaccine, such that the spike protein won't be changing shapes, and antibodies could be generated once and for all. So that is probably one of the reasons, but studies will have to be conducted for the science to really objectively identify why we have that observation.
Excellent. We really are, living through and as Dr. Ault-Brutus, I think, said, building the plane as we fly it. Thank you all for those great questions. Just to wrap up quickly, we know the COVID-19 vaccine is a critically important tool to help us stop this pandemic. But as all of our speakers have said, at one point or another, stopping the pandemic requires us using all the tools we have available. The combination of getting vaccinated and following CDC's recommendations to protect ourselves and those around us will offer the best protection. So we got to keep on wearing those masks, and we have to keep on washing those hands often and vigorously. We have to keep on keeping a safe physical distance from others, and we have to get the vaccine when it's our turn. And together we can reduce the spread of this nasty virus, and we can get us closer, move closer to that light at the end of the tunnel. I want to say a huge thank you to our speakers and to all who joined us today. Thanks to Hofstra School of Health Professions and Human Services, and to Dean Syrup and Assistant Dean Porcelli. Thank you again. It was really informative. I hope everybody stays safe and stays well. We will share the presentation and the contact information, and I want to wish you all a good evening. Thank you, everybody.